All right, so we're going to be covering musculoskeletal trauma and non-traumatic fractures. All right, so we can kind of skip all this stuff. All right, so you may get some questions about like this, like what are some of the basic functions of the skeleton system, your musculoskeletal system? Obviously, it provides form for the body, it provides shape, it provides protection. It's what we use for movement, and the big one down here, it is a big portion of what produces our red blood cells in our bone marrow. That's where they come from. Okay, so make sure you know the 3 different types of muscle groupings and what they are. Okay, so cardiac is all by itself. Cardiac obviously pertains to the heart. Your involuntary are known as your smooth muscles. These are the internal organs that just operate all on their own. The others are your voluntary. These are ones that allow the body for movement. Those are known as your skeletal muscles. So skeletal are the ones that provide movement. Involuntary are your internal organs, and cardiac is all by itself as the heart. Know the difference between tendons and ligaments? So I always struggle with this, remembering which one's a tendon, which one's a ligament. Muscle to muscle, or excuse me, muscle to bone or bone to bone. So the way I remember it is, and this is probably a dumb way, is that alphabetically, L is earlier in the alphabet than T. So I think bone to bone, 2 B's, B and L, that's closer together than T and M, muscle and tendon. So I know that's dumb, but that's just how my brain associates it together. So that's how I put it together. So bone to bone is ligament, and I think, okay, B and L, that's on one half of the alphabet, and tendon and muscle, muscle to bone, that's on the other half of the alphabet. That's how I remember it. Again, it's probably not the best way. I should probably just know it, but sometimes I need help. This just explains, some just visualization of what a tendon is versus what a ligament is. Like we said, a ligament is bone to bone. So here you can see it. These are like your ACL, your LCL. So like your anterior cruciate ligament, your LCL, your lateral cruciate ligament. And then you have these 2 up front that kind of crisscross over your kneecap. What's the term for your kneecap? Do you know? That is known as your patella. That bone is called the patella. And then we see the tendon, okay, which is muscle to bone. And here it just kind of breaks down what a joint looks like. Okay, so yes, this is a musculoskeletal lecture, but some other things that are important here are things like the bursa sac that provides a little cushion here. So if this becomes inflamed or infected, that's when someone has bursitis. Okay, so you might hear people with tennis elbow. Okay, that's bursitis. That's an inflammation of the bursa. It's typically from repeated usage. Not repeated usage, but repeated motions. So tennis elbow, they're doing the same thing over and over and over again. Correct. Yeah, exactly. So this just breaks down the 6 different types of motion. The 2 that people get confused on are adduction and abduction. So the easiest way to remember this is adduction is you're coming to the body, you're adding to the body, and abduction is you're going away from the body. So you're adding to the body, you're bringing in, ab, away from. So if you're listening to this, you can't see what I'm doing right now, but there's a visualization that goes with this that help further understand what I'm talking about. So there's the skeletal system is broken down into 2 different portions, your axial and appendicular. And I believe that it's broken down here. No, we don't have photos of it. Okay, so the axial skeletal system is your head, your chest, and your vertebral column. Okay, everything else is going to be your appendicular skeletal system. So that includes your extremities, including your upper extremities. Okay, the shoulder girdle, pelvis, and down. All right, so this just kind of breaks down, the skeletal system as it is. If you don't know something, especially when you're writing your notes, just describe where the location is. If you can't remember, humerus is the long bone in the arm. Okay, just the patient's upper arm. You know, possible upper arm fracture. If you can't remember, just go with that. Likewise, if you can't remember like the medical term for the shoulder blade, that is the scapula, just write shoulder blade. Okay, likewise, collarbone, the clavicle, you can't remember the name, just go with basic English. People will understand. All right, so fractures. What are fractures and why they happen? So a fracture is a break in the continuity of the bone, and you can have open and closed. When we talk about open and closed, we're talking about, does it break through the skin or does it stay intact? Does the skin stay intact? Okay, the bone is obviously fractured, but we're talking about open or closed. Is the skin open or closed? And then osteoporosis is a degenerative bone disorder that just kind of weakens the integrity of the bone and makes it easier for them to break. All right, signs and symptoms: pain, tenderness, deformity, discoloration. Obviously, we know that through DCAP BTLS, we know a deformity is a misshapen extremity, or anything that is misshapen. Paresthesia. What is paresthesia? So paresthesia is that numbness or tingling. Okay. Paresis or paralysis, okay, is the inability to move, and then you may have decreased pulse and perfusion. So that's one thing that I stress when doing your assessments, is to actually get a palpated radial pulse on both extremities at the same time. And if you suspect a fracture, you should check the PMS, pulse, motor, and sensory, at the same time, because you may have one extremity that has good, adequate perfusion, and the other does not. Or maybe it has weak bounding, or a weak thready pulse, and the other has a strong bounding pulse. Okay, so I always encourage them to get it done at the same time. That way you can compare the two. Here's just a photo of a fracture of the forearm. Okay, we can tell what bones are fractured. Radius is one of them. The humerus is up there. That's the ulna. That's an ulna and radius fracture. Okay, that we see right there. And here is the visualization of that outside of the X-ray. Here's the different types of fractures. You don't necessarily need to know all of these for your exam, or even for the real world, because it doesn't matter. A fracture is a fracture. You're still going to treat it virtually the exact same way. That means you're going to splint, where you can check PMS, you're going to splint, you're going to check PMS again, you can provide pain relief. So it is good to know these things, but it's not going to be that big a deal, because you don't have X-ray vision. You're not going to be able to definitively tell what type of fracture the patient has. Okay, so complications of fractures. Obviously, hemorrhaging, that's the one that we are most afraid of, okay? Because when bones fracture, they become very, very sharp, okay? Especially your femur. That can become like a knife. And it doesn't take much for those bones to lacerate surrounding blood vessels. So that's why splinting is so important, because we want to make sure that the patient, is fully capable of surviving, and so splinting them down is going to be integral to that. Okay, so talking about strains and sprains. So a strain is an overexertion or overstretching of muscle fibers, causing it to tear. Okay. When a sprain, okay, is an injury to a joint capsule. So this with a sprain, you typically see a lot of swelling. Strains, no such swelling or no discoloration. So it says usually localized with no edema, i.e. swelling or discoloration. So we shouldn't see any bruises or anything like that. But with sprains, we typically see a lot of swelling and discoloration going on. So here's just a breakdown of it. All right, when we talk about dislocations, so nothing is broken on a dislocation, or actually, maybe that's not true. You could have a break and the dislocation, but for most dislocations, an example in this photo we see right here, okay, nothing is broken, but we probably have some ligaments and tendons that are damaged, either torn or just stretched to the point that the bone has dislocated. So dislocation in the knee joint. All right. What did we say the knee bone was called? The patella. The patella. All right. So general injury considerations. We're talking about musculoskeletal stuff. So deformities. Okay, they could be a fracture or a dislocation. We're not necessarily going to know. With my experience, dislocations typically cause um, more PMS impairment than fractures do. So a dislocation like this, in my experience, checking the dorsalis pedis, there's more likely, this is all anecdotal evidence, that there's more likely going to be some problems with the perfusion, the pulse down here. All right, so always assess the mechanism of injury and signs and symptoms when we're talking about any type of musculoskeletal injury. Obviously, the MOI is going to be very important. Was it a fall? Was it a motor vehicle collision? All these things are going to be important when we talk about this. And this just kind of continues on direct force, indirect force, or twisting, because your twisting may result in like the spiral fracture that we saw here in this slide, like we see on the one, the second furthest to the right. You may get a spiral fracture from a twisting motion. Where are we at? All right, so femur and the pelvis. We're talking about critical fractures here. The potential for significant bleeding can be life-threatening. So you may get a test question on this when it talks about how much can you bleed out. So it says 1.5 liters, okay, or 1,500 mLs of blood for each femur. So that means that theoretically you can lose 3 liters of blood if both femurs are fractured, okay? We have a bilateral femoral fracture, and it has lacerated some blood vessels. We can lose around 1,500 mLs per leg. Yeah. So for women, this is on average, it's about 4 to 5 liters for their total blood volume, and men, it's about 5 to 6. So that is incompatible with life. You will die, absolutely be dead at 50% blood loss. All right, so bones are highly vascular, so the bones themselves bleed as well. That's why the bones of the femur and the pelvis, they both contain a large amount of blood supply. And like I said, this is where we also, in the bone marrow, the marrow cavity that you see here, that's where red blood cells are created. There's other things that are created as well. You had your lecture on the immune system a couple weeks ago. We know that B and T cells are also created there. Okay, so our bones will also, work hand in hand with the immune system. All right, so bones or joints. We can only suspect fractures unless they're obvious. That is, they are poking through the skin, okay, as in an open fracture. Some fractures may have external hemorrhaging, all right? So bleeding and shock control is always going to be important. So for a fractured femur, throwing on a tourniquet and then providing shock control is going to be very, very important. All right, so deformities, contusions, tenderness, swelling, and discoloration. That DCAP BTLS is always going to be important when we're assessing these patients. Checking for skin color, CTT, color, condition, and temperature is going to be very important. PMS, okay, is the pulse, motor, and sensory present? It says here, this is important. One attempt should be made to realign a fracture to retrieve a distal pulse if it's not present. That is, if we have a tib-fib fracture, okay, and we do not have a distal pulse, so we're checking the dorsalis pedis, and we do not have a pulse. We can make one attempt to realign the bone, and if it doesn't work, we give it up. All right, what did we say these two bones were? The lower bones of the arm?
That's the radius
Ulna and radius. Nail it. All right, this is a closed fracture, okay? Closed fracture. So we have we have possibly a tib fib. I don't know exactly what's going on because there's no x-ray of it. But then we have something going on with the ankle as well. So like I was saying before, we're going to classify open and closed. Okay, closed, there's no break in the skin. Open, there is. And with an open fracture, that's the easiest way to most definitively say, like, yes, there is a fracture. I can literally see the bone. But then there's other times with a closed fracture. For example, this is an example of a closed fracture, but it's very obvious that something is broken. All right, 6 P's. Definitely know these. Okay, pain, pallor, paralysis, paresthesia, pressure, and pulses. So what does pallor mean again? That's something that people tend to forget. Think pale. Okay, that's the whiteness. Are they pale? So are they in pain? Is the skin going white? Okay, is it blanching? So think about when we put a tourniquet on ourselves. Okay, we're healthy individuals, and we get that blanching of the skin because there's no blood flow. Likewise, if we have some blood flow cut off to an extremity due to a fracture, you may get that pallor, that paleness in that extremity, and you may get that blanching. Paralysis, the inability to move it. Paresthesia, that numbness and tingling. Pressure, maybe they're not having pain, but they just feel a buildup of pressure. And then pulses, we want to assess the pulse. And like I was saying earlier, it's important to always assess both extremities. Both extremities, okay? Assess them at the same time so that you can compare. Did you get all the notes? Did you get all these? I saw you write them down.
Sorry?
Did you get these? I saw you write them down.
Oh, yes.
Okay, good. All right, so this is obviously an open fracture. Okay, the skin, the continuity of the skin is broken. All right, we can see the bone protruding through. All right, this is a foot. We can see that the larger bone and the ankle are just protruding. Okay. Always put on PPE. Okay, maintain inline stabilization of the spine if indicated. O2. You're probably going to want to provide some type of shock support here, so keeping the patient warm. But as far as the injury itself, applying cold packs and elevating may be indicated here. Have you guys ever heard of the acronym RICE? RICE? Rest, ice, compression, elevation. So rest, ice, compression, elevation. So obviously keep the patient off of that extremity, okay, or whatever the fracture is. Don't have them using it. Ice it using cold packs. Sometimes compression helps, okay, especially for splinting. And then elevate the extremity. All right, so here's just some signs and symptoms, okay, bruising, pain, swelling, deformities, tenderness, so on and so forth. One thing that's really not talked about a lot here, when we talk about DCAP BTLS, another acronym I like to use when it comes to fractures is called TIC, T-I-C. That's, is there tenderness, is there instability, and is there crepitus? Crepitus being that bone-on-bone grinding, okay? So if you're palpating the individual and you feel that bone-on-bone grinding against each other, you know that you have a fracture. Okay, you're going to reassess the vital signs every 5 minutes. You're going to recheck your interventions, and that is so important. That's something people just kind of do. They just kind of set and forget. But you need to reassess your interventions to ensure that they are still effective. For example, let's say we put someone fractured their wrist, and we put a splint on them. All right, we reassess, and then 5 minutes later, we reassess again, and they no longer have a pulse. Okay, maybe the swelling that has occurred has now created a tourniquet-like effect because of the bandaging that we were using, and now they did have a pulse initially, but now their PMS has been compromised and we have no pulse. So constantly reassess not only your vitals, but your interventions as well. Just talking about splinting, okay, we use this to prevent movement of dislocated joints or possibly fractures, okay, to reduce further injury and to reduce complications. That is, we don't want to see them go from having a pulse to no longer having a pulse. So splinting is something that assists with that a lot. So basics of splitting. So here's some complications that can occur: restriction of blood flow, excessive bleeding, increased pain. This is from your fractures, and this is why we want to splint someone. So we're going to assess PMS, cover the wound, align the limb if possible. Remember, you only get one shot at it. Hold traction until the splint is applied, and especially for the femur. So you guys have seen the oh gosh, what's it called? Traction splint. So the traction splint, that is exclusively for a femoral shaft fracture. Okay, it needs to be the shaft of the femur. And when you see someone that actually has a femoral fracture, okay, they're in intensive pain. Once you hold traction on it and you're actually pulling those bones to realign, the pain it's not complete, but the relief that you see that person exhibit is night and day. So being in the Army, doing jumps and doing, as a medic, having to do, I forgot what it's called. Drop zone. Okay, so doing drop zone coverage. So when people are jumping on the birds, all right, sometimes they fracture their femurs, okay, because they're doing bad jumps, poor mechanics. And I've had to use these before, and just it's night and day difference on the relief that they have.
You can't use those if they have any fractured hip or fractured knee, right?
Correct. That is exclusively isolated femur shaft. So if you can't hear, the question was, and he was just kind of stating, like, you cannot use those if they have any injury or fracture to the pelvis or knee. Like I said, that is exclusively for the femur shaft, the shaft of the femur. You're going to assess PMS, okay? Cut away the clothing, expose the injury, sterile dressing, okay? Wrap the wound, or pad as necessary, splint, maintaining traction if necessary. All right, so here's just a couple different types of splinting. We're not going to go too deep into this. All right, examples of splints. Here we see the traction splint. We're just talking about this. Vacuum splints. Vacuum splints are great, but they're one and done usage, and they're more expensive than just your SAM splints. So money rules everything. So these are not very common in the field. All right, but they are great. You can improvise. You can use a towel, a blanket, a pillow. Okay, all those things work great, especially for ankles. A pillow splint works wonders. So some things that are considered hazards here is that maybe the EMT or paramedic even, they kind of get some tunnel vision and they delay transport while trying to splint the extremity. Is splinting something we can do en route? Absolutely. So let's not delay transport when we can get them to definitive care and definitive treatment. Always check PMS, okay, line if necessary. Like I said, I'm reiterating this one more time. You get one shot at realigning, and then reassess. Checking that PMS over and over again. Here's just examples of splitting a long bone. Okay, we've all covered this in class, so we're not going to do this too much. And they're using a vacuum splint. All right, so we know that joints, okay, we talked about ligaments. Ligaments are bone to bone. Tendons are muscle to bone. All right, so we may get some ligaments that are stretched and possibly torn. So we may have to splint a joint. All right, so when it comes to splinting a joint, these vacuum splints are the bee's knees, okay? Because you want to splint in place. All right, so this person right here, they're manually stabilizing the joint, that is this person's right knee, and you ideally you want to splint it in place. You don't want to fully extend that leg and then splint unless the patient prefers it that way. And here we're using a vacuum splint, and they're able to splint it in place. That's why these things are great for joints. And then they are just reassessing the dorsalis pedis, okay, checking PMS. All right, femur fractures can be accompanied by bleeding, severe bleeding, and severe pain. All right, so if you're on a BLS truck, you don't have access to a lot of the pain meds that paramedics do, but if you're riding with a paramedic or your partner's paramedic, they're probably going to give the patient some fentanyl to control the pain because it is extreme. All right, do not use a traction splint if they have any knee, hip, or pelvis injuries, like we just talked about before. If there's any type of amputation, and then avulsion. What's an avulsion? You guys remember? Flap of skin. So if you ever see a test question where it talks about a flap, when talking about some type of injury, they're referring to an avulsion. Here's just the how-to for a traction splint. This is one thing people forget all the time. I don't know why. The ischial strap, I don't know why. It's an integral part of it, but people forget to use it. Okay, again, we're just kind of going through here for the different types of traction splints. This is a unipolar, okay, so there's only one pole for this. These are not, in my opinion, not great. The bipolar, okay, so this one, where you can see there's two poles on either side of the leg, those are infinitely better than the unipolar ones, my opinion. This is how to place a sling and swath. I showed you guys how to do this, so we are not going to beat a dead horse. This is a humerus injury. What's the humerus? What bone? Yep, the upper arm. All right, so here's a joint injury. So they're splinting it in the position of comfort for these individuals, kind of bent. All right, but this is why a vacuum splint is just so much more efficient than doing something like this. This works, okay? But it kind of looks like crap, but it doesn't matter. If it works, it works. But a vacuum splint would be much more ideal for a joint like this. Here's another example of a humerus injury. Here's the joint. Okay, using that vacuum splint in the bent position. Okay, it's great. Here's the straight. And check out what they have going on down here. Okay, remember how when we splinted the patient's arms, when I had the same splint, I asked you guys to kind of roll up one end to allow the patient to rest their hand there. What do they have him doing? They have him squeezing some Curlex. Okay, that just allows the hand to rest in a comfortable position. They're already in a bad way. Don't make it worse for them. Additionally, we talked about RICE. You weren't here for it. Do you know the acronym RICE? When we talk about injuries like this? If you don't, that's fine. Well, guys, what does RICE stand for? Rest, ice, compression, and elevation. What are they doing with his arm? Elevating it, okay? Compression, all right, they may or may not put some ice packs on there, but they're already knocking out two of those four. The compression and elevation is going on there. Like I said before, you want to get the hand in a position of comfort, so we kind of roll up the SAM splint. Just more examples of this, using a SAM splint for a lower leg injury. Using a pillow, okay, or a blanket, like I said, for an improvised splint. So this is somebody that's just fractured just their fingers. If you have nothing else in the world to splint a finger to, what can you tape a finger to splint it? The other finger, okay? If you have nothing in the world, just buddy tape it and then put finger to finger. All right, so What type of injury is this? What bone is this? Femur. Okay, mid-shaft. So this would be ideal for what? Traction splint. Exactly. Okay, as long as there's no injury to the pelvis, knee, okay, or anything else going on in the hip. I'm not sure exactly what they're trying to refer from just that image there. All right, so this is using an air splint, or also known as a pneumatic splint. My problem with these, and why we have to constantly reassess things, and is important, because these can pop, and if it pops, it's not working. Okay, so I'm not a fan of pneumatic splints like this. All right, here's another example of an improvised one. Did you guys talk about this in class at all, PASGs? Okay, probably not. These have been largely phased out. This stands for pneumatic anti-shock garments. Okay, and I'll pull up a photo at the end. They've basically been phased out. Nobody really uses these things anymore. Even 20 some years ago, when I first went through EMT school, they were like, yeah, nobody uses this. Because it can cause complications to other injuries, especially if they have any internal abdominal injuries. All right, so a pelvic splint, you need a pelvic binder. And if you don't have a pelvic binder, like the commercial one that they're using here, okay, you can just use anything to go under the pelvis and then tie it around. Even if you have to tie two cravats together and then go under the pelvis and just tightly secure it. Okay, to create an improvised pelvic binder. But this is a commercial pelvic splint or pelvic binder. And anybody that has a fractured pelvis or it's unstable, this is going to be a requirement to moving them safely. On these, so when you are pulling this, you'll hear a click. And that's what's so great about the commercial ones, is that it's going to tell you through an audible sound as far as you need to go. If it's an improvised one, you just gotta hope that what you're doing isn't causing any further damage and is also helping them. That's why it's, best to always have these commercial ones, because when it's ready, when it's at that point, when you're pulling, you'll hear click, and these will pop up. These two little buttons right here. All right, compartment syndrome. What is compartment syndrome? Do you guys know? Did they explain this well? Probably not. Okay? A lot of people don't understand what compartment syndrome is, even though it's a very simple concept. It is when you have blood entering an area, but it cannot escape. Okay? So think of it this way. Arteries do what? They bring blood away from the heart, okay? With a lot of pressure or little pressure? A lot of pressure. That's why in arterial bleeds, you have that spurting, okay, because there's a lot of pressure. So venous blood going to the heart or away from it? To the heart, okay? A lot of pressure or little pressure? Less pressure, okay? So let's say that you have a fractured extremity, okay? You have an extremity that's fractured. It starts to grossly swell up, okay? So that swelling may compromise the ability for venous return. So the arterial, it's under a lot of pressure. It's able to push past all that swollen tissue. It's able to get blood to where it's trying to go, but the veins don't have as much pressure, so they cannot return it. And that's called compartment syndrome. When you have a buildup of pressure due to blood that cannot return back to the heart. And so what happens is that the tissue becomes hypoxic, okay? It becomes hypoxic overall because it's just not getting its adequate perfusion. We're not taking the waste away. The cellular waste is not being taken away. It's all just getting trapped in that compartment, hence compartment syndrome. So these patients, they complain of severe pain and burning in compartment syndrome. Paralysis is a possibility. You may get that paresthesia, that numbness and tingling that we talked about before in the 6 Ps. Okay, the extremity may feel hard to palpation. Why would it feel hard? Well, it has such a buildup of blood that is just rigid. Okay, you may see that in, I know we're talking about musculoskeletal, but like think about abdominal injuries. When they have internal bleeding in their abdomen, the abdomen gets very hard and rigid. We may see the same thing here in our extremities if we have a lot of blood building up in those compartments. Oh, right here. Distal pulses and motor sensory functions may be normal. Okay, you may still have a pulse. So like I said, you have the arterial bleed, you have the arterial pressure. It's able to get blood past that spot. We feel a pulse, but the venous return just isn't happening. All right, so these are special considerations. We're nearing the end of this lecture. We're talking about children here, pediatrics. Okay, the child skeleton is constantly growing. You may see these terms, okay, I have a hard time pronouncing this term, but epiphyseal, okay, segments. We're talking about growth plates, okay? Fractures at growth plates are very bad for the child because it could impact their growth or equal growth of the extremities. And then this is always important because we always have to be advocates for our patients. Fractures in pediatrics may be indicative of abuse, especially when the story is inconsistent with the mechanism. All right, so if you have a patient that has, let's say, a fractured leg, okay? They have let's say they have a fractured femur, okay? They have a fractured femur, and the story from the parents is that the patient fell out of bed. And they're like, oh, okay, show me where the bed is. All right, children's bed, they're typically not very high off the ground. They're pretty low because they're children. All right, you're probably not going to sustain a fracture to the femur in a fall of 6 to 8 inches. You get what I'm saying? So the patient's condition needs to be consistent with the injury, or with whatever they're telling you caused the injury, the MOI. All right, blood loss due to long bone and pelvic fracture in the pediatric is less frequent, okay, but it still can happen. Treat for shock. How do we treat for shock as EMTs? Oxygen. Yep, keep them warm, stop the bleed, give them O2, transport. Here, if they have a fracture, splint it. Splint these fractures, especially if they're showing signs of shock. That means that the fracture is probably bleeding, or it has lacerated some blood vessels, causing the bleeding, and we need to get to the hospital as quickly as possible. In our geriatric patients, we talked about this earlier, with osteoporosis. The condition that leads to this is called osteopenia. Okay, this is more often found in older women. Okay, older women are more prone to fractures, especially the neck of the femur, referred to as a hip fracture. Okay, so why do you think women are more prone to this than men? What 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 do we call that phase of life where women go through in probably middle to later age? Menopause. Okay, that severely affects their hormone regulation. Okay, which leads to lower bone density. That's why we see these more often in women. All right, most common fracture in older adults, often from falling with an outstretched arm. This is called a foosh, F-O-O-S-H, fall on outstretched hand. Because what do people do once they're falling over? How do they try to catch themselves, right? They stick their arms out. Especially if they're older, okay, they're more likely to break their bones. All right, the most common lower extremity fractures in older adults: ankles, hips, pelvis, tibia. All right. What's the other bone in the lower leg? You have the tibia and the fibula. All right. So, which one's the larger of the two? Tibia. Okay. Easy way to remember that. Okay. The tib fib. Think of a little white lie. What is a little white lie known as? A fib. Okay, a little white bone. Think of it that way. This is the smaller of the two. All right, still talking about non-traumatic fractures. Okay, this can be caused by a diseased bone. All right, we're talking about individuals with cancer, osteoporosis, or other conditions. All right, that can cause this. And then the rest of the slides are just case studies that we are not going to go into.